Hi, I am Merrina. Today we're going to start reading chapter 10 of Better by Atul Gawande. Last time we talked about chapter 9. It was whether doctors should keep fighting for their patients even when there's a small chance of recovery and the patient is going through a lot of pain. Today, chapter 10 is called The Score. I'm not sure what that means either, but it seems to have something to do with having babies. So, let's start reading. At 5 a.m. on a cool Boston morning not long ago, Elizabeth Rourke, a thick black-brown hair, pale Irish skin, and 41-week pregnant, preached over and woke her husband. "Chris, I'm having contractions," she said. "Are you sure?" he asked. "I'm sure." She was a week past her due date, and the pain was deep and vice-like, nothing like the occasional spasm she's been feeling. It seems to come out of her lower back and to wrap around and seize her whole abdomen. The first spasm woke her out of her sound sleep. Then a second hit came, and a third. She was carrying their first child. So far, the pregnancy had gone well. Aside from the exhaustion and the nausea for the first trimester, when all she felt like was lying down on the couch and watching Law and Order reruns. "I can't look at Sam Waterston anymore without feeling kind of ill," she says. An internist who had just finished her residency. She had landed a job at the Massachusetts General Hospital a few months before and managed to work until she was full term. She and her husband now sat up in bed, timing the spasms by the clock on the bedside table. They were 7 minutes apart, and they stayed that way for a while. Rourke called her obstetrician's office at 8:30 when the phone were turned on, but she knew what the people there were going to say. "Don't come to the hospital until the contractions are 5 minutes apart and last at least a minute. You take the childbirth class and they drill it into you a million times," Rourke said. The whole point of childbirth classes, as far as I could tell, was to make sure you keep your butt out of the hospital until you are really in labor. The nurse asked if the contractions were 5 minutes apart and lasted more than a minute. No. Had she broken her water? No. Well, she had a good start. But she should wait to come in. During her medical training, Rourke had seen about 50 births and delivered 4 babies herself. The last birth she had seen was in a hospital parking lot. They had called saying, "We're delivering. We're coming to the hospital, and she's delivering," Rourke said. "So we were in the ER and we went running. It was freezing cold. The car came screeching up to the hospital. The door went flying open. And sure enough, there the mom was. We could see the baby's head. The resident running next to me got there a second before I did, and he puts his arms down, and the baby went thump right into his arms, into the middle of the parking lot. It was freezing cold outside, and can never forget the stream pouring off the baby. It was blue and crying, and the stream was pouring off of it. Then we put this tiny little baby on this enormous stretcher and raced it back into the hospital." This is so funny, delivering in the parking lot. But I'm glad that it went well. I'm glad the baby just came straight out. Like there's no other weird stuff going on. Rourke didn't want to deliver in the parking lot. She wanted a nice, normal vaginal delivery. She didn't even want an epidural. "I didn't want to be confined to bed," she says. "I didn't want to be dead from the waist down. I didn't want a urinary catheter to have to be put in." Everything about the epidural was totally unappealing to me. She was not afraid of the pain. Having seen how too many deliveries had gone, she was mainly afraid of losing her ability to control what was done to her. She had considered hiring a doula, a birthing coach, to stay with her during delivery. There are studies showing that having a doula can lower the likelihood a mother will end up with a C-section or an epidural. The more she looked into it, however, the more worried she became about being paired with someone annoying. She thought about delivering with a midwife, but as a doctor, she felt that she would have more control working with another doctor. She was not feeling very much in control at the moment, though. By middays, her contractions hadn't really speeded up. They were still coming every 7 minutes, maybe every 6 minutes at most. She was finding it increasingly difficult to get comfortable. The way it felt best was, strangely enough, to be on all fours, she recalls. So she just hung around the house like that, on all fours, during the contractions. Her husband close by, both of them nervous and giddy about their baby being on the way. Finally, at 4:30 in the afternoon, the contractions began coming 5 minutes apart, and they set off in their Jetta, with the infant car seat installed in the back. Her bag packed with everything that the Girlfriend's Guide to Pregnancy had said to bring, right down to the lipstick, which she doesn't even wear. When they reached the hospital admissions desk, she was ready. The baby was on the way. She was eager to bring it into the world, as nature had intended it. I want no intervention, no doctors, no drugs. I didn't want any of that stuff, she says. In a perfect world, I want to have my baby in a forest bower attended by fairy spirits. This lady is very funny. I also like fairies and fairy tales and stuff. Human birth is an astonishingly natural phenomenon. Carol Burnett once told Bill Cosby how he could understand what the experience was like. Take your bottom lip and pull it as far away from your face as you can, she said. Now pull it over your head. The process is a solution to an evolutionary problem: how a mammal can walk upright, which requires a small, fixed, bony pelvis and also possess a large brain, which entails a baby whose head is too big to fit through that small pelvis. Part of the solution is that, in a sense, all human mothers give birth prematurely. Other mammals are born mature enough to walk and seed food within hours. Our newborns are small and helpless for months. Even so, human birth is a feat involving an intricate sequence of events. This is so fascinating. I never thought that humans give birth prematurely. I thought, well, the babies are living when they're outside, so they're doing fine. But turns out we have to let the babies come out earlier, otherwise their heads get too big and they get stuck. This is a fun fact to learn. First, a mother's pelvis enlarges. Starting in the first trimester, maternal hormones stretch and loosen the joints, holding the 4 lobes of the pelvis bones together. Almost an inch of space is added. Pregnant women sometimes feel the different parts of their pelvis moving when they walk. Then, when it's time for delivery, the uterus changes. During gestation, it is a snug, rounded, hermetically sealed porch. During labor, it takes on the shape of a funnel, and each contraction pushes the baby's head down through that funnel into the pelvis. This happens even in paraplegic women. The mother does not have to do anything. Meanwhile, the cervix, which is, through pregnancy, a rigid, more than inch-thick cylinder of muscle and connective tissue, capping the end of the funnel, softens and relaxes. Pressure from the baby's head gradually stretches the tissues until it is paper thin, a process known as effacement. I don't know how to pronounce it. A small circular opening appears, and each contraction widens it, like a tight shirt being pulled over a child's head, until the contraction pulls the cervix open for about 4 inches, or 10 centimeters. The full temple-to-temple diameter of the child's head the child cannot get out. So the state of the cervix determines when birth will occur. At 2 or 3 centimeters of dilation, a mother is still in early labor. Delivery is many hours away. At 4 to 7 diameters, the contractions grow stronger. Active labor has begun. At some point, the amniotic sac surrounding the fetus breaks under pressure and the clear fluid gushes out. Contractile force increases further. At between 7 and 10 centimeters of cervical dilations, the transition phase, the contractions reach their greatest intensity. The contractions press the baby's head into the vagina and the narrowest part of the pelvis bone ring. The pelvis is usually wider from side to side than front to back, so it's best if the baby emerges with the temples, the widest portion of the head, lined up side to side with the mother's pelvis. The top of the head comes into view. The mother has a mounting urge to push. The head comes out, then the shoulders, and suddenly a breathing, wailing child is born. The umbilical cord is cut. The placenta separates from the uterine lining, and with a slight tug on the cord and a push from the mother, it is extruded. The uterus spontaneously contracts into a clenched ball of muscle, closing off its bleeding sinuses, the expanded veins in the uterine wall. Typically, the mother's breast immediately let down with colostrum, the first milk, and the firstborn can latch on to feed. That's if it all goes well. At most, any step, the process can go wrong. For thousands of years, childbirth was the most common cause of death for young women and infants. There's risk of hemorrhage. The placenta can tear and separate, or a portion may remain stuck in the uterus after delivery and then bleed torrentially. Or the uterus may not contract after delivery, so that the raw surfaces and sinuses keep bleeding until the mother dies from blood loss. Sometimes the uterus ruptures during labor. Infection can set in. Once the water breaks, the chances that bacteria will get into the uterus rise with each passing hour. During the 19th century, the Semmelweis discovered doctors are introducing infection because they examined more infected patients than midwives did, and because they failed to wash their hands when they're contaminated. Bacteria routinely invaded and killed the fetus, and often their mother with it. Fever remained the leading cause of maternal death in the era before antibiotics. Even today, if a mother does not deliver within 24 hours after her water breaks, she has a 40% chance of being infected. The most basic problem is obstruction of labor, not being able to get the baby out. The baby may be too big, especially when pregnancy continues beyond the 40th week. The mother's pelvis may be too small, as was frequently the case when the lack of vitamin D and calcium made rickets common. The baby might arrive at the birth canal sideways, with nothing but an arm sticking out. It could be a breech, coming butt first and getting stuck with its leg up in its chest. It could be a footling breech, coming foot first but then getting wedged at the chest with the arm above the head. It could come out head first but get stuck because its head is turned the wrong way. Sometimes the head makes it out, but the shoulders get stuck behind the pelvic bone of the mother's pelvis. These situations are dangerous. When a baby is stuck, the umbilical cord, the only source of fetal blood and oxygen, eventually become trapped and compressed, causing the baby to asphyxiate. Mothers have sometimes labored for astonishing lengths of time, unable to deliver, and died with their child in the process. In 1817, for example, Princess Charlotte of Wales, King George IV 21-year-old daughter, spent 4 days in labor. Her 9-pound boy was in a sideways position, with a head too large for Charlotte's pelvis. Only after the 50th hour of active labor did he finally emerge, stillborn. 6 hours later, Charlotte herself died from hemorrhagic shock. As she was George's only child, the throne passed to his brother instead of hers, then to his niece, which is how Victoria became queen. Wow, this is so interesting. If Princess Charlotte was able to properly deliver the baby, Queen Victoria would never be queen. How cool is that? But still, it's horrifying to read that she spent so many days in labor and the baby and her both died. So I'm very glad that we have a lot of great technologies and women are dying at a much lower rate in childbirth. Midwives and doctors long sought ways out of such disasters, and the history of ingenuity in obstetrics is the history of these efforts. The first reliably life-saving intervention for mothers was called a crochet, or in another variation, a cranioclast, a long, sharply pointed instrument, often with claw-like hooks, which birth attendants used in desperate situations to perforate and crush a fetus's skull, extract the fetus, and save, at least, the mother's life. Wow. That's the first time I've learned about this, but yeah, like in desperate cases, saving the mom is pretty important because you can always have a new baby, but if the mom dies, then it's gonna be sad. Many obstetricians and midwives made their names by devising ways to get both a mother and baby going through obstructed deliveries. There is, for example, the Lovost maneuver for a breech baby with its arm trapped above the head. You take the baby by the hips and turn it sideways, then reach in, take an upper arm, and sweep it down over the chest and out. If a breeched baby's arms are out, but the head is trapped, you have the Marisol Smiley Viet maneuver. You place your finger into the baby's mouth, which allows you to pull forcefully while still controlling the head. The child with its head out but a shoulder stuck, shoulder dystocia, will asphyxiate within 5 to 7 minutes unless it is freed and delivered. Sometimes sharp downward pressure with a fist just above a mother's pubic bone can dislodge the shoulder. If not, there is the Wood's corkscrew maneuver, in which you reach in, grab the baby's posterior shoulder, push it backwards, and free the child. There's also the Rubin maneuver. You grab the stuck anterior shoulder and push it forward toward the baby's chest to release it. And the McRoberts maneuver. Sharply flex the mother's legs up onto her abdomen, and so lift her pubic bone off the baby's shoulder. Finally, there is the maneuver that no one wanted to put his name to, but that have saved many babies' lives through history. You fracture the clavicles, the collarbones, and pull the baby out. Wow, okay. I guess if you fracture the baby's bones, it's gonna grow back, and everyone lives, so it's interesting that there are so many ways to get the babies out. There are dozens of these maneuvers, and though they have saved lives of countless babies, each have a significant failure rate. Surgery has been known since ancient times as a way to save an entrapped baby. Roman law in the 7th century BC forbade burial of an undelivered woman until the child has been cut out, in the hope that the child would survive. In 1614, Pope Pope Paul V issued a similar edict, ordering that the child be baptized if it was still alive. But the cesarean section on the living mother was considered criminal for much of history, because it almost always killed the mother through hemorrhage and infection, and her life took precedence over that of the baby. The name cesarean section may have arisen from the tale that Caesar was born of his mother Aurelia by an abdominal delivery, but historians regard the story as a myth, since Aurelia lived long after his birth. Only after the development in the late 19th century of anesthesia and antisepsis, in the early 20th century of a double-layer suturing technique that would stop an unopened fetus from hemorrhaging, did cesarean section become a real option. Even then, it was held in low repute, and that was because a better option was around, the obstetrical forceps. The story of the forceps is both extraordinary and disturbing, because it is the story of a life-saving idea that was kept secret for more than a century. The instrument was developed by Peter Chamberlain, the first of a long line of French Huguenots who delivered babies in London. It looked like a pair of big metal salad tongs with two blades shaped to fit snugly around a baby's head and handles that locked together with a single screw in the middle. It let doctors more or less suck babies out, and carefully applied was the first technique that could save both the baby and the mother. The Chamberlains knew they were onto something, and they resolved to keep the device a family secret. Whenever they were called in to help with the mother in obstructed labor, they ushered everyone else out of the room and covered the mother's lower half with a sheet or a blanket so that even she could not see what's going on. They kept the secret of the forceps for 3 generations. In 1670, Hugh Chamberlain, in the 3rd generation, tried and failed to sell the design to the French government. Late in his life, he divulged it into an Amsterdam-based obstetrician, Roger Roentgen, who kept the technique within his own family for 60 more years. The secret did not get out until the mid-18th century. Once it did, it gained wide acceptance. At the time of Princess Charlotte's failed delivery in 1817, her obstetrician, Sir Richard Croft, was widely reviled for failing to use forceps to assist. In remorse for her death, he shot himself to death not long afterwards. Wow. So the doctor who failed to deliver Princess Charlotte killed himself. That's very sad. It isn't necessarily his fault that she died, but back when she was like the only heir to the king, like the king would probably have executed him either way. So by the early 20th century, the problems of human birth seem to have been largely solved. Doctors could avail themselves of a range of measures to ensure a safe delivery. Antiseptics, the forceps, blood transfusions, a drug that could induce labor and contract the uterus after delivery to stop bleeding, and even in desperate situations, cesarean section. By the 1930s, most urban mothers have shifted from midwife deliveries at home to physician deliveries in hospital. But in 1933, the New York Academy of Medicine published a shocking study of 2,041 maternal deaths in childbirth in New York City. At least 2/3, the investigators found, were preventable. There had been no improvements in death of newborns in the preceding 2 decades. Death rates for newborns had actually increased. Hospital care brought no advantage. mothers were better off delivering at home. The investigators were appalled to find that many physicians simply didn't know what they were doing. They missed clear signs of hemorrhagic shock or other treatable conditions, violated basic antiseptic standards, tore and infected women with misapplied forceps. The White House followed with a similar national report. Doctors may have had the right tools, but midwives without them did better. The two reports brought modern obstetrics to a critical turning point. Specialists in the field have shown extraordinary ingenuity. They had developed the knowledge and instrumentation to solve many problems of child delivery. Yet knowledge and instrumentation have proved grossly insufficient. If obstetrics wasn't to go the way of phrenology or trepanning, it had to discover a different kind of ingenuity. It had to figure out how to standardize childbirth. 3/4 of a century later, the degree to which birth has been transformed by medicine is astounding and for some alarming. Today, electronic fetal heart rate monitoring is used in more than 90% of deliveries, intravenous fluids in more than 80%, epidural anesthesia in 3/4, medicines to speed up labor. The drug choice is no longer ergot but pitocin, a synthetic form of the natural hormone that drives contraction in at least half. 30% of American deliveries are now by C-section, and that proportion continues to rise. The field of obstetrics had changed, and perhaps irreversibly, so have childbirth itself. An admitting clerk led Elizabeth Rourke and her husband into a small triage room. A nurse midwife timed her contractions. They were indeed 5 minutes apart, and then did a pelvic examination to see how dilated Rourke was. After 12 hours of regular painful contractions, Rourke figured that she might be at 7 or 8 centimeters. Instead, she was at 2. Interesting. It was disheartening news. Her labor was only just starting. The nurse practitioner thought about sending her home, but eventually decided to admit her. The labor floor was a horseshoe of 12 patient rooms strung around a nurse's station. For hospitals, deliveries are good business. If mothers have a positive experience, they stay loyal to the hospital for years. So the rooms are made to seem as warm, as inviting as possible for what is essentially a procedure room. Each has recessed lighting, decorated winter curtains, comfortable chairs for the family, individualized climate control. Rourke even had a jacuzzi. She spent the next several hours soaking in the tub, sitting on a rubber birthing wall, or walking the halls, stopping to brace herself with each contraction. By 10:30 that night, the contractions had sped up, coming every 2 minutes. The doctor on duty for her obstetricians group performed a pelvic examination. Her cervix was still only 2 centimeters dilated. The labor had stalled, if it had really started. The doctor gave her 2 options. She could have active labor induced by pitocin, or she could go home, rest, and wait for true active labor to begin. Rourke did not like the idea of using the drug, so at midnight she and her husband went home. No sooner was she home than she had realized she made a mistake. The pain was too much. Chris had conked out on the bed, and she couldn't get through this on her own. She held out for another 2.5 hours just to avoid looking foolish, and then got Chris to drive her back. At 2:43 a.m., the nurse scanned her in again. She was still wearing her barcoded hospital identification bracelet. The obstetrician re-examined her. Rourke was nearly 4 centimeters dilated. She had progressed to active labor. Rourke began to feel her will fading, however. She had been having regular contractions for 22 hours and was exhausted from sleeplessness and pain. She tried a narcotic called Numbane to dull the pain, and when that didn't work, she broke down and asked for an epidural. An anesthesiologist came in and had her sit on the side of the bed with her back to him. She felt a cold, wet swipe of antiseptic along her spine, the pressure of a needle, and a twinge that shot down her leg. The epidural catheter was in. The doctor gave a bolus of local anesthetic into the tubing, and the pain of the contractions melted away into numbness. Then her blood pressure dropped, a known side effect of epidural injections. The team poured fluids into her intravenously and gave injections of ephedrine to increase hers and her baby's blood pressure. It took 15 minutes to stabilize her blood pressure, but the monitor showed that the baby's heart rate remained normal the whole time, about 150 beats a minute. The team dispersed at around 4 a.m. and Rourke fell asleep. At 6 a.m., the obstetrician returned and, to Rourke's dismay, found she was still 4 centimeters dilated. Her determination to avoid medical interventions ebbed further, and a pitocin drip was started. The contractions surged. At 7:30 a.m., she was 6 meters dilated. This was real progress. Rourke was elated. She rested some more. She felt her strength coming back, and she readied herself to start pushing in a few hours. Dr. Alessandra Pesse took over with the new day and looked at the whiteboard behind the nursing station, where the hourly progress of the mother in each room is recorded. In a typical morning, a mother in one room might have been pushing, while a mother in another was having her labor induced with medication. In still another, a mother might be just waiting, her cervix only partially dilated, and the baby still high. Rourke was a G2P0 41.2 weeks Pete plus 600 minus 2. I don't understand what that means, so there's a better explanation here. It says a mother with 2 gestations, 0 born. She has had a previous miscarriage, 41 weeks and 2 days pregnant. She was on pitocin. Her cervix was 6 centimeters dilated and 100% effaced. The baby was at -2 station, which is about 7 centimeters from crowning. That is, from becoming visible at the vaginal orifice. Pesse went into Rourke's room and introduced herself as the attending obstetrician. Pesse, who was 42 years old and had delivered more than 2,000 newborns, projected a comforting combination of competence and friendliness. She had given birth to her own child with a midwife. Rourke felt that they understood each other. Pesse waited 3 hours to allow Rourke's labor to progress. At 10:30 a.m., she re-examined her and frowned. The cervix was unchanged, still 6 centimeters dilated. The baby had not come down any further. Pesse felt along the top of the baby's head for the soft spot in back to get a sense of which way it was facing, and found it facing sideways. The baby was stuck. Sometimes increasing the strength of the contractions can turn the baby's head in the right direction and push it along. So using a gloved finger, Pesse punctured the bulging membrane of Rourke's amniotic sac. The waters burst out, and immediately the contractions picked up strength and speed. The baby did not bulge, however. Worse, on the monitor, its heart rate began to drop with each contraction. 120, 140, it went, taking almost a minute before recovering to normal. It was not always clear what dips like these mean. Malpractice lawyers like to say that they are a baby's cry for help. In some cases, they are. An abnormal tracing can signal that a baby is getting inadequate supply of oxygen or blood. The baby's cord might be wrapped around its neck or getting squeezed off altogether. But usually, even when the baby's heart rate takes a prolonged dive, lasting well past the end of the contraction, the baby is fine. A drop in heart rate is often simply what happens when the baby's head is squeezed really hard. Dr. Pesci couldn't be sure which was the case, so she turned off the pitokin drip to reduce the strength of the contraction. She gave Rourke, and therefore the baby, extra oxygen by nasal prong. She scratched the baby's scalp to irritate it and make sure the baby's heart rate responded. The heart rate continued to drop during contraction, but it never failed to recover. After 25 minutes, the decelerations finally disappeared. The baby's heart rate was back to being steadily normal. Now what? Rourke had not dilated any further in 5 hours. The baby's head is stuck sideways. She has been in labor for 30 hours to this point, and her baby didn't seem to go away anywhere. So I'm guessing she's gonna have to get C-section, because otherwise she's gonna have the baby stuck there for way too long, and it wouldn't be safe for either of them. This chapter is quite long. I will stop here and we'll pick up next time, and we'll find out what happens to the mom and the baby. Thanks for being with me, and bye.